Sanjay was talking about pre-mixed insulin, and one of the things that he actually said was that the reason why that basal insulins are not the first choice and the pre-mixed are the choice is because in India we start the insulin later. The average HbA1c of when you start insulin in India is almost 9.4 to 9.7, which is very much higher than the European population. But if you are a good physician and if you want to start insulin earlier, basal insulin still is a very good option in type 2 diabetes. So fundamentally, these are my disclosures. And why do you want to start insulin in type 2 diabetes? Because I'm focusing on basal insulin use in type 2 diabetes. Now, one of the things is insulin has a predictable response in whatever be the type of patient, irrespective of his BMI, his age, and level of hyperglycemia. At diagnosis, you know that a major proportion of beta cells are already gone, and the beta cell reserve is very little. And insulin has been used almost 100 years and is the most reliable agent to treat diabetes today. Asian Indians have more severe loss of beta cells, or some other studies have been done, and we are not very much that worried about the weight gain in patients, especially because they are not that obese. As I told you, the response to insulin is very predictable, and then what you can see here is insulin has been shown to be the most well-tested and well-trusted anti-hyperglycemic. So using insulin in any type of diabetes, irrespective of any other criteria, you're not wrong, absolutely. Now the question is, why basal insulin? One of the things is that you want to first fix the fasting, and in order to fix the fasting, you have to suppress the hepatic glucose production. So it can mainly target the fasting hyperglycemia by using basal insulin. No oral hypoglycemic agents other than metformin can target the fasting plasma glucose. And fasting hyperglycemia contributes to cumulative glycemic burden for the whole 24 hours. And therefore, lowering fasting glucose results in decrease in postprandial effect, which is called the carryover effect. So basal insulin has a role to play in treating type 2 diabetes. And lastly, basal insulin can probably change the natural history of type 2 diabetes if you start it very early. Now this, the concept which I'm going to propose to you. You have seen this slide number of times, that you decrease the fasting and you reduce the whole complete blood glucose for the whole day. But we have a concept, and if you read textbooks of diabetes, you will read that type 2 diabetes is a progressive disorder. Whatever be that strategy that you will use beta cells, and the HbA1c keeps going up. And that has been based on the large prospective trials which have been monitoring HbA1c over the years. First, the UKPDS showed that whether insulin, chlorpropamide, glipizide, all that's an old study, used very old drugs, still it showed the deterioration in HbA1c over the years, and they said this is a typical type 2 diabetes anywhere in the world. More recent, you have the ADOPT trial, which also showed. But the only long-term trial which actually shown a difference in this has been the ORIGIN trial, where insulin was actually started very early in type 2 diabetes. In fact, 12% of the patients in the ORIGIN trial were not having even type 2 diabetes. They had impaired glucose tolerance. So basal insulin was started at a very early stage in type 2 diabetes, and the inclusion criteria was cardiovascular risk plus cardiovascular events, and the patient is only on a single oral hypoglycemic agent. So for 7 years, we were keeping the HbA1c to started 6.4, ended up in 6.2. So I think we may have to rewrite the textbooks and say that you can probably change the natural history of diabetes. Type 2 diabetes need not be a progressive disorder if you probably use the right tools and the right strategy to treat diabetes early. The ideal basal insulin should work for more than 24 hours, should be peakless, should not have hypoglycemia, should be weight neutral, should normalize fasting plasma glucose, and should be safe for the heart, kidney, and should mimic the physiological release of insulin. These are the ones that you have starting. But now the idea of using, or the concept of using basal insulin or night dose of insulin, that is the first thing. Even before the insulin analogs came into market like the glargine or the degludec, you had the first papers coming from Scandinavian countries. Sanjeev is sitting here, came with the night dose of insulin, NPH was used by Jarvinen and et al. And showed for the first time you have better control of diabetes because the fasting is normalized and you do not end up in weight gain and you have decreased risk of hypoglycemia. Those are the three important takeaways. But then you still had the problem of hypoglycemia and still had the problem of the waning of the insulin action over time. So now you have the new ones. The glargine was a big revolutionary product in insulin in 2002. Then you have detemir, then degludec, and you have now the glargine 300 for your use here. So the three things I'm going to talk about is glycemic control, hypoglycemia, and the real world evidence. Glycemic control, there are several studies. The first 5 are on type 2 diabetes, the last 2 are on type 1 diabetes. Degludec significantly is better than glargine in 3 studies in type 2 diabetes, but there was no significant difference between degludec and glargine in the glycemic control, but what we had was in hypoglycemia actually. So I'll give you a couple of trials and I want to take your time. The Toshiba audit is a retrospective data extraction for those patients who are on any basal insulin converted into IDEC. And the primary aim was to look at the HbA1c reduction, and the secondary aim was to look at hypoglycemia. And what you find is that definitely there was a better improvement. That means in degludec controlled diabetes better than the previous basal insulins used in the European trial. So it had an advantage. The second point was again the fasting plasma glucose also came down like the HbA1c. There was a significant reduction. So they said degludec is better than any other basal insulin. I think the most important thing is hypoglycemia. I think it is not the HbA1c. There are a number of trials. This is the switch 2 trial where glargine 100, which is the benchmark of basal insulin, was compared with IDEC on a switchover, crossover study. And what was very interesting was that there was a 46% numerically lower rate of severe hypoglycemia with IDEC compared to U100 glargine. There was a 30% lower rate of overall symptomatic hypoglycemia and almost 42% reduction in nocturnal symptomatic hypoglycemia. Pretty good, I think. DEVOTE trial. Now, any agent which is to be, any hypoglycemic agent which is to be introduced in the United States have to go through a cardiovascular outcome trial. The question is insulin safe for the heart? Well, they did a big trial, which is a very bold one. The ORIGIN trial was a cardiovascular outcome trial where basal insulin was compared with standard therapy in early type 2 diabetes. And that showed neutral effect. And it showed that insulin did not increase cardiovascular events, so it was cardiac safe. This is a still bolder one where the 2 basal insulins, namely glargine and degludec, were compared for a cardiovascular outcome trial. The results showed on the left-hand upper corner, there was no difference in MACE, so the cardiovascular event rates, either treated with glargine or with degludec, was not different. But the byproduct of this study was hypoglycemia. Severe hypoglycemia was reduced almost by 40% in degludec compared to glargine, and also nocturnal severe hypoglycemia further was reduced almost by 53%. So that was a good takeaway message from this particular study rather than the cardiovascular outcome. So degludec did not increase cardiovascular risk. Well, we can say it was neutral effect from glargine. But it significantly showed very powerful reduction in the frequency of hypoglycemia. So that was a good message. So all the trials showed that degludec was superior to any previous basal insulins which were used for treating type 2 diabetes. Of course, the final thing comes again from real world evidence. You may actually criticize real world evidence is not a randomized controlled study, but today we have more interest in real world experience because it actually generalizes the whole concept and the proof is better. So this is the confirmed studies, the clinical outcome assessment for effectiveness of insulin degludec in real world medical practice from large medical records from the United States, showing a comparative effectiveness of insulin degludec and insulin glargine U300. So that may be a question that you have in your mind. Because U300, which came much later after the degludec was introduced, and what it showed was this is a secondary use of data from the medical records. Patients on insulin naive were either put on insulin degludec or insulin glargine, and the primary endpoint was change in HbA1c for at date up to 6 months, and also looking at hypoglycemia. And as you can see, there is a significant reduction in HbA1c and little 0.02 pp value, which is significant, 1.5 compared to 1.2 in 6 months' time. And this shows that degludec provided a greater reduction in hypoglycemia, both in total 30% lower reduction in hypoglycemia, and this was more than one episode or even multiple episodes, both were much less. So when you use a basal insulin, the most important advantage is that you can use insulin with confidence without producing hypoglycemia. There is a question about insulin titration of the dose, and the dose that you use calculate for insulin naive patients is about 0.2 to 0.4 per kilogram body weight. So that's the formula that you use. To summarize, I'm on time. The insulin degludec, introduced a couple of years ago, has a unique mode of protraction for long duration of action. Now, it is important to mention here a study called the BRIGHT study, which is again a randomized control trial done by the Sanofi, which actually compared degludec, the U300, in a randomized control trial for efficacy and hypoglycemia. And what it showed was that the efficacy was not different, and even hypoglycemia was not different, except that in the titration period, there was a decreased percentage of hypoglycemia in the glargine 300 compared to degludec. But the randomized control trial did not show any major difference in the BRIGHT study. But I showed you that the real world evidence with the larger numbers did show that actually degludec had a superiority as far as the frequency of hypoglycemia is concerned. So to conclude, degludec has shown better control of diabetes over any of the basal insulin used previously, and it had significantly better reduction in HbA1c. It also had significantly reduction in the rates of hypoglycemia in blinded studies as well as from the real world evidences. Thank you. I think I'm on time.